Good morning, everybody. What an honor to be here. Thank you very much to the Memorial Group for the amazing invitation. Thank you, Murat, for our friendship. I wouldn't be here without you. My name is Alexander Haese. I'm a urologist at the Martini Klinik in Hamburg, and I'd like to share our experience with the single-port robotic surgery system on prostate cancer. The Martini Klinik itself is a little bit of a strange place because unlike the Memorial Group who treats every patient, every disease and is excellence all across the medical fields, we are urologists and we decided not to be proper urologists anymore, but we just choose to do prostate cancer surgery, and that's what we do every single day. And we had the honor to start the single port program a little bit more than 2 years ago, and I'd like to share my experiences with you. The robotic program at Martini Klinik is quite an old one, if you want to put it like that. We started in April 2004 with our first robotic prostatectomy. As per today, we are looking at more than 14,000 robotic prostatectomies done so far. We had 12 surgeons. We have 6 robotic platforms available in our institution for Da Vinci X system, a Hugo, and the single port system as the most recent one. We are a Da Vinci training center since 2011 and have trained a number of surgeons in lots of countries across Europe. We are exceedingly happy with the robotic program that we have, and there's always the rule, never change a winning team. And when we looked back at our robotic program, and we could see that over the years it has surpassed the quality of the open prostatectomy easily, with similar oncological outcomes and improvement in continence and potency. We say, why should we change something that works so well with a multi-port platform? Why should we change a winning team? And the response to that is that we feel that the single port opens a new door for us as urologists and as prostate cancer surgeons, and it will open more doors for real urologists and of course across all other surgical specialties. And the reason why is it is true that at least at this point in time a multi-port transperitoneal prostatectomy is sort of the gold standard. It's extensively described. We have long-term oncological and functional and data outcomes available. We will not have, and I guess we will not see randomized trials comparing single port versus multi-port, but the extraperitoneal approach of the single port or the transvesical approach for the single port or even the transperineal ports, they are all new access types that we might want to contemplate for certain patients or for improved patient outcomes. So the reason why we choose the single port is and Martini Klinik is an established center for multi-port prostatectomy. We do have standardized patient report outcome measurements across decades of all the patients that we do, so we can easily compare the outcomes by all kinds of metrics that you would like to see. We know our results as individual surgeons, so each of us as a surgeon gets a biannual report on his continence, on his potency data, of the patients, of course, just to be precise on that one, on positive surgical margins. And therefore, we know how to handle data and can measure the outcomes of new platforms. And that helps us to validate if a new platform that comes in actually does what it's supposed to do or if it even improves outcomes. And for us, the single port is really the first new advancements in robotic surgery. We've been working with robots since 2004 with a standard platform, and we have seen a beautiful evolution in multi-port system over the years, but they are all basically improvements, new iterations, but really not a new technology. And the single port is the first real new technology on the robotic market. And of course, we are curious surgeons who we want to challenge, we would like to reproduce and potentially improve what others have done with the single port before. Short overview on what you can expect during the talk. I give you some views on experiences on our case selection, on cart positioning, basically practical stuff like where to put the patient, what kind of team do you need to do a robotic prostatectomy with a single port, what kind of accessories do you need, very kind types of access, some videos and some results. I will share you some feedback from our anesthesiologists who love the system actually from day one, and some other considerations on the single port use in the future. First of all, everything starts with case selection, and when you start a new technology, a new surgical system, you would like to do it on the best possible cases, because you start something from you and you do not want to make a start more challenging than necessary. So the patient positioning, patients is positioned in roughly a 10-degree mostly, or sometimes up to 25-degree Trendelenburgs. We used to have smaller prostates at the beginning, less than 60 cubic centimeters, and low or intermediate risk patients, because we wanted to do not more than a limited lymph node dissection if necessary. Initially, we said patients should not have had previous urologic surgery of the prostate like TURPs or HoLEPs. After some experience with about the 100th procedure, we said we allow larger prostates up to 80 grams. So far, the largest we have done was 125 grams. We now allow TURP or HoLEPs before, because we learned how to handle the system, and after all, it's not so difficult to do a prostatectomy with a single port than with a multi-port. It's the same technology, but you want to be sure. Initially, we said patients should not have laparoscopic meshes because of the extraperitoneal approach, and after a while we discovered that it is actually not so difficult, in particular when you have a one-sided mesh only, then you can easily find your extraperitoneal way on the side where there is no mesh and take it from there. And initially we said BMI less than 30, and now we permit up to 35 in BMI. Still no salvage surgeries, so no patients after, for example, radiotherapy or HDR. And as your experience increases progressively, you include levels of complexity. That is the normal evolution. Things like open hernia repair, things like an umbilical hernia repair or previous abdominal surgery are actually beautiful cases and have no worries about a single port access. This is some typical pictures for beautiful single port cases. You see a patient who had a colostomy a couple of years ago, and of course that would be something that you would find extremely challenging on a multi-port transperitoneal approach. With the single port, as you do, we just actually moved the incision from the midline, which you see a little more to the right lower corner, and could do a prostatectomy in quotes as if there was nothing before. Other incisions like that, big cuts, which make you worry if you can do a transperitoneal multi-port approach, no problem whatsoever on a single port prostatectomy. About the patient positioning and the cart positioning, this is what it looks like. The patient is resting on the table. You have a nurse and assistant. I come back to that later. And the patient, the boom or system cart comes back, in our case, from the left-hand side. But because it has a boom, literally you can place the system wherever you want. It's always doable and takes less space than a multi-port system. One of the important things is the degree of Trendelenburg. One of the beauties of the extraperitoneal approach is that we use less Trendelenburg because you simply don't need it because the peritoneum remains close. But still, you might have some challenges. For example, if you have a very slim patient with a BMI on the very low end and a smaller prostate, 10 degrees of Trendelenburg, which is something that is almost nothing, is beautiful. But of course, the more difficult it seems, the more you can increase the degree of Trendelenburg. For example, larger prostates and higher BMI, you just add a few more degrees. That is absolutely no problem. And when you see or encounter a situation during your procedure where you say, I just want to add more degree and add more degree degrees of Trendelenburg, you can just do it with the system operating. That is very easy to do. Basic insufflation tools will do. If you have a standard insufflator, you just need one. We don't need anything more complex than that. If you do have an air seal for other reasons, then you can do it, of course, but you don't need it. Of course, we need a suction tool, and this is something that you can do dirt cheap, because you just steal an 80 French nasogastric tube from your anesthesiologist and do put 2 small nodes at each of the ends, because you need to grasp the tool by yourself. And that is basically your suction tool. This suction tool is what you connect to a normal laparoscopic sucker, as you see here. And these are then tied to the draping of the patients, and then they enter, as you see in the lower right corner, they enter through what we call the goldfish glass into the patient. The setup is very straightforward. You see the patient lying in 10 or 15 degrees Trendelenburg. You do your incision about 10 centimeters above the symphysis. You do a vertical cut of about 2 to 3 centimeters, depending on the size of the prostate. Of course, you need to increase it, but it's just one horizontal cut. Then you establish the extraperitoneal space that we are familiar with, but unlike you see it on the left hand, we do not need a balloon. You just use your fingers to swipe down the peritoneal space, the ratio space. And subsequently, you put in the so-called access ring, you put on the sleeve, and then you connect the access kit, which is the plastic bowl that everybody calls the goldfish glass, that is basically connected to the system. You see that you dock the system, and you need to set a pitch limit. The pitch limit is basically the lowest level that the boom go down, just to avoid that it doesn't hurt the face of the patients. You put in the instruments, and then you are ready to go. And this, from first incision until you drape or wash out, in a normal situation, we have seen and worked together with Murat, it takes maybe 5 minutes or so. And one of the beauties of the system is that you can work as a double team. It's quite common in practice to have a multi-port prostatectomy done as a triple team with a surgeon, a bedside surgeon, and a scrub nurse. And on the single-port procedures, it's extremely efficient and cost-effective, because we just work exclusively with one dedicated nurse. So it's only the 2 of us that help us going through the procedure. That nurse has to be ambitious, though, and it's also a nice tool to select and maybe create a specialty team of nurses, because they need to do everything that's left. They need to be skillful enough to place all the sutures, all needles through the opening, through the access kit, and at the same time also need to operate the suction devices as per your instructions. Can we start the right video as well, please? So what you see here, and I just put 2 videos side by side. Is it possible to start the right video as well? Because it doesn't seem to start automatically. Because I don't know, I can. Okay, excellent. So what you see here on the right hand is exactly the same scene that I do on the multi-port. On the left hand, it's a single port. We are doing cutting the bladder neck and separating the prostate from the bladder. And you see that things are virtually identical. So if, for example, you are a seasoned multi-port surgeon and you say, what is going to happen? What can I do? How do I need to do my procedure X, in this case a prostatectomy? The answer is you will be able to do your single-port prostatectomy in exactly the same way as you would like to do your multi-port prostatectomy. You see the subtle differences hidden in there. You might see on the right-hand side that there's a suction tip waiting for things to happen, whereas on the left-hand side, I, as the operating surgeon, need to use the suction with my own left hand and clear the field, of course, of blood, and you also see clear the field of smoke. but you see the movements and the way you do shape your preparation around, in this case, the anterior bladder neck, is absolutely identical. So this picture should show you and demonstrate you that if you think about, is it going to be difficult? Is it a big challenge? Do I need to start from zero when I go into a single port? And the answer would be no, you would not need to do that. This is another short video clip. Can you please again start on the right-hand side, where we do the nerve sparing procedure, and you see on the right hand again, it's the multi-port device that uses where the suction and the clip applicator is operated by the bedside surgeon, whereas on the left-hand side, on the single port, I need to do all the traction and reconstruction and exposure. So this is basically how it looks like. This is what the setup. And now the typical question that everybody asks, I'm an experienced surgeon on a certain procedure, and I start with a new system. I will see a patient tomorrow where I say, Mr. X, you are patient number 1 for our single port procedure. What can you tell him? Can you tell him, I'm not quite sure what's going to happen, what you will not know? And to find out and to clarify this, what we have done is we have compared our first 605 Da Vinci single port procedures of 6 surgeons. So there are 6 number 1 patients in there for each of the surgeons versus the multi-port prostatectomy procedures of the same 6 surgeons, and each of these 6 surgeons has an experience of more than 1,000 multi-port procedures. So very beginners of single port, very advanced multi-port procedures. What can you expect? First of all, and this is just a short look back in time when we looked at 173 patients, you see the influence of surgical experience on the change of the time to catheter removal, blood loss, and operating time. And we split these 173 patients into 6 groups of equal size. So the first 29 on the very left, second 29, and so on until the 6th ones. And you see from the very beginning, we have a very consistent length of catheter stay of about 6 days. But you could see that in the first 29, the operating time was around 194 minutes, and it quickly dropped by more than 30 minutes in the second one to 161. And if you go all across to the right-hand side, the average length of surgery now is about 146 minutes in this group of patients, and the blood loss has slowed down or has gone down from 300 to 200. So the evolution is quite quick in terms of length of OR. What you see here is now the real comparison. So on the left column, the advanced multiport, 2,322 procedures versus the initially mentioned 605 single port. And the first line tells you the average surgical experience. So we are comparing here a surgeon with an average experience of 1,500 multiport procedure versus an average single port experience of 76. So it's 0.5% of the experience on the single port. You do see the distribution of pathological stages, which is slightly moving towards the single port patients in terms of smaller and less aggressive cancers. One of the key features for quality of life, of course, is the ability to do a nerve-sparing procedure to preserve the neurovascular bundles for return of erectile function. In a single port, we could do 96% of all cases in a bilateral nerve-sparing versus only about 80% in the multi-port procedures. A critical outcome in terms of oncology is, of course, what is the surgical margin status? Do we have clear surgical planes? And we can see that the negative surgical margin status in the multiport is somewhere around 89% and 93% in the single port. So certainly on a oncologic outcome basis, there doesn't seem to be much of a difference. Blood loss is the same, and slightly longer, 13 minutes average time of surgery for the single port. The in-hospital stay is remarkably long, and I know most people kind of amuse themselves about this kind of fact that in Germany patients stay in the hospital so long. It's simply a matter of reimbursement, but they do not differ. What we have seen initially is that the length of catheter stay in the multi-port procedures is somewhat shorter, and that reflects a little bit more the attention to detail that a single port surgeon needs to do when he's suturing and doing the anastomosis. We are simply, at this point in time, a little bit more careful and testing the anastomosis a little bit later than usual. What we have seen in terms of clavien complications is overall a quite happy outcome, but one thing remains to be seen. The clavien 3A and 3B complications, so those complications that require a somewhat surgical intervention, something like, for example, a puncture. And due to the extraperitoneal approach, we have seen in particular in the very early phase more lymphoceles. And that required us to do at the end of the procedure to fenestrate the peritoneum in patients who had undergone a lymph node dissection, and that has almost completely made the lymphoceles disappear. But we noted that there is more lymphoceles in the extraperitoneal approach, somewhat similar to the open prostatectomy earlier. Other than that, the complications are very favorable in terms of 4As and 0 to 2. One of the most important things, of course, that people ask us is how is the continence? Continence is one of the measures of quality after surgery, and what we always do is we measure continence at various times after surgery. We measure it at 1 month, we measure it at 6 months, and we measure it at 12 months after surgery. And even though the picture is very detailed, if you look on the right-hand side, you do see there's literally no difference between the continence rate, early or intermediate or long-term continence, between a very beginning single-port surgeon and an advanced multi-port surgeon. So if you ask your patients, if they ask you, do I need to be scared because I'm patient number 1 or 2 or 3 and you have done hundreds of multi-port procedures, do I need to be afraid of receiving inferior outcome because I'm the first one? You can easily say that this is not the case. What is notable is the lymph node yield. I mentioned to you earlier that we are not doing high-risk patients which require a very high lymph node dissection up to the common iliac artery. That is certainly a difficult thing to do in a single-port prostatectomy, and you can see that we do get less lymph nodes on average on a single port than we get on a multi-port. It's really a matter of practice and something that you have to learn on top. But generally, if you summarize what an advanced multi-port surgeon can do when he switches to single port, you will have a similar rate of nerve sparing and a similar rate of negative surgical margins. You have a very short, slightly shorter time of surgery and shorter time of bladder catheter in the multi-port. You have comparable early and mid and long-term continence, but you have somewhat higher rates of lymphocele formations, and you get more lymph node yields in multi-port. What you see here is, again, just to illustrate how the OR time develops over time. And what you see on the right, the reddish dots, this is my OR time somewhere in the range between 2,500 and 3,200. So what it basically, and each dot, of course, is the length of the surgery, and you see that the OR time does not evolve anymore. It just takes me about 140 to 150 minutes, no matter how I do it. And on the left-hand side, the greenish part is the OR time development of my personal series. And of course, the first case took quite a while, and the second one also took quite a while. But you see that after around 50 to 60 procedures, you are as quick, as fast as you are as compared to your 3000th multiport. So the evolution, the length of surgery is developing rather quickly, and I can tell you that those surgeons that I trained afterwards in our clinic, they are doing much faster than I did, because everything else is already set up. They train with trained nurses. The Trendelenburg is one of the things that make a difference in the single port procedure. What you see on the left hand is the 30-degree Trendelenburg that we apply on the transperitoneal multiport approach. On the right hand side, the 10-degree Trendelenburg, and thus does make a lot of a difference. And I asked actually our anesthesiologists to give me some feedback, how they feel about it, if they could just write some notes on it. And they produced a bunch of slides about it, about multiport and single port. And in multiport, they said that you can look at the, in quotes, improvement in quality on the single port versus multiport in many ways. You can just look at it simply from a time perspective. And if you have a multiport, it requires you to have invasive blood pressure measurement because of the extreme Trendelenburg, which takes 10 minutes longer induction time. Usually, because of the steep Trendelenburg, they spend simply more time in the recovery room because it has higher ventilation pressure and they have higher narcotics need. And all this is obviated in a single port, made much faster. They say, look at it in terms of the materials and disposables you need. You need longer positioning for a multiport, more positioning materials, invasive, the material for the blood pressure measurement, higher need of anesthesia due to greater invasiveness, and all this again is simplified by the single port. And when you look at the stuff that you need, for a multiport, they say it takes more stuff to actually do a multiport procedure because they stay longer in the recovery room. It just collects more stuff. The OR time is similar, but the length in the recovery room is significantly shorter in single ports. You say, look at it from the ventilation perspective. Ventilation is a big thing, and because in a multiport where we have the capnoperitoneum, we have diaphragmal pressure which is high, extreme Trendelenburg brings elevated peak pressures and maximum pressures up to 35 millimeters mercury, and you have an elevated risk of barotrauma. And because of the extraperitoneal approach, all this again is avoided and makes the anesthesia so much more slick. There's one difference. We have a little more cutaneous emphysemas during the procedure, but these disappear rather quickly. In terms of hemodynamics, it's simply more difficult from a hemodynamic perspective. They say to do a multiport prostatectomy, you have more variations on the cardiac work, reduced preload, reduced right ventricular function, etc., etc. All these things that eventually lead to reduced myocardial oxygen uptake, these things are completely avoided in a single port procedure. And that is why a single port procedure is also more suitable for patients who have elevated cardiovascular risk profile. And finally, it's less invasive. You have no puncture of the arterial radialis artery, so no harms on that one, no narcotics needs. It's a single cavity procedure. And finally, positioning damages like on the shoulders, on the arms, all that which is associated with a multiport, this is simply avoided by a single port. So in short, there's many ways that maybe as you as a surgeon would like or like the aspects of a single port, but you can be sure that your anesthesiologist will find multiple aspects that also make the single port much more appealing to them than a multiport procedure. So you might ask yourself, what are the questions and answers some people usually say about multiport? And when you say, I have a specific technique, a specific suture that I use, and the answer is, If you use your sutures in a multi-port, use the same sutures in the single port. And if you have specific instruments for laparoscopic devices that you use, of course you would use the same Maryland grasper, or you would use the same needle to bring in and out needles, no difference. The only difference is, of course, that you do not need the suction to operate by yourself. When you say, I have developed a certain technique in my multi-port procedure, whatever that is, and I can tell you, you will be able to replicate your prostatectomy with a single port in exactly the same way. You do not need to learn a radical prostatectomy once more, you just do it. The only thing you need to learn is how to operate the device, but that works, as I showed you, rather quickly. When you say we are used to work as a triple team, I would strongly encourage you, not only for the sheer pleasure and for the silence in the room, because 3 people chat more than 2 people, to work as a double team, but also for efficiency. You will not regret it, and you will ask yourself, why should I ever do 3 people on that one? Because it's super smooth. When you say, I'm used to a transperitoneal view, and I can only encourage you, we have done thousands and thousands of transperitoneal prostatectomy, and switching to the extraperitoneal is super slick, and it's actually, as urologists, the extraperitoneal space is where we belong to anyway. And then the question, shall I go pure single port, which we do, just one single incision, or should I add a second trocar? My comment would be, as you wish. And I can tell you, when I started, I sort of insisted to say, I want to have a second trocar. My proctor said, no, you don't. I said, yes, I want. No, you don't. I want to have it. Okay, he said, okay, place it and you'll see. And we haven't used it once, and we haven't used it in the second procedure. It says, he told you, you don't need it. I said, okay, I admit you are right. So it's really, even though you think I should have one, you don't need it. Still, if you want to have it, place it, but you will find out that there's no need for it. Multi-port and single port, same, but different. Of course, it's teamwork, but you will be only 2. Of course, because you have additional workload to do, you need to juggle with more tools than before, in particular when you're choosing pure single port. And I explained it to you, if you know how to juggle and you keep 3 balls in the air, that's what a multi-port procedure is. And a single port is, they just give you 2 balls more. You know the principle, it's just a little bit more practice to keep 5 balls in the air, but it's the same. We use wristed instruments on a single port as well as on the multi-port, but on the single port you need to use your elbows a little bit more, because the wristed function is less prominent and the wrists are more distal to the ends of the joint. And some people, I never done it, but some people who know laparoscopy or who've done say, this brings me back some movements that I learned during laparoscopy experience. It's a way of reprogramming muscle memory. The surgical approach is the same, but you need to change your instrument position a little bit more often. I didn't show that on the video, but for the optimal exposure of the organs, it's helpful to switch the positions of the instruments every now and then. The camera is straight, but also flexible, and that means you have more viewing options to consider, which we, using rigid scopes, are not so much used to. And for the hemostasis, we usually do not use titanium clips as in a multi-port, but the bipolar energy is a good replacement. Once more, a short video on differences. As you see what I'm again doing on the dorsal bladder neck here, you see the suction is sort of lying around there at this moment in time. You need to go back and forth, and you see this is the flexible camera. You sort of need to play with it to have what you find a good viewing angle. What is noticeable is that, of course, the extraperitoneal space is smaller. So if you have smoke, like you see it here, it fills more quickly with smoke. So you have to have a good, careful bedside surgeon, nurse, who takes care on cleaning and evacuating. And of course, when you suction, because the space is smaller, it collapses more quickly. So you need to have some sense of suction operation. But other than that, and here again you see myself going back and forth with the instruments, other than that, it is not really a difficult thing. A little bit of practice, but we as surgeons, we should be willing to practice every now and then. Other aspects, again, all of them, all single ports are double team, 35% of multiport are double team, all of them pure single ports, all of them extraperitoneal. When we do a lymph node dissection, we learn to fenestrate the peritoneum at the end of the procedure. We have no conversion so far, so the system works remarkably well, had no complications. We went through the learning curve quickly, did the 100th procedure 5 months after installation. So far 605 and 16 live procedures today, so it's well established. And also, when we think beyond urology, what is a single port good for? It is really an amazing tool for others. At Martini, the NT surgeons have started using the multiport for transoral surgery, which for them is something that they say we haven't even thought about the possibilities, what we can do with it. Also, again, for the patient benefit, because when they do their laryngeal carcinoma, they avoid the split of the mandible. They just go through an open mouth, and that is, of course, a loss or a reduction in morbidity that is almost beyond belief. General surgeons have started, and that means a multidisciplinary approach for a single port uses or increases its efficiency. It creates visibility in a very competitive field, and you as an individual surgeon, you distinguish yourself or your clinic or your hospital from others, and you remain at the cutting edge of technology. And from my perspective, to learn something new and develop as a surgeon, I find this deeply satisfying. And that is why there's lots of aspects just beyond the procedure that I would like to encourage you to go through a single port experience. Despite all enthusiasm, this is what has happened as well. We had one patient who died, which actually was the third patient of all who was a proctored case. He died due to a pulmonary embolism, which was horrible, of course. We had 3 patients of the 605 who had a revision due to bleeding, which we had to go back. One patient had a hematoma in the prostatic bed, which we caused an anastomotic insufficiency, which we had to evacuate. There is clearly a learning curve in the fenestration of the peritoneum, and patients required laparoscopic fenestration because of a persistent lymphocele, and 3 patients in the very early phase developed a secondary insufficiency following catheter removal about 2 to 3 weeks later. We have no idea why that happens, but it hasn't happened since these 3 patients initially. Further things that we will evaluate in the long term is postoperative pain, where we see it on the wards already, and in terms of the painkillers that patients need, that we expect clearly a significant difference in terms of the single port. Things like time to first bowel movement clearly experience a difference in favor of single port. And of course, we need to have long-term proper oncology and functional outcome. But those results so far, that seem very encouraging. So, conclusion, final step, final slide. When you start with a single port procedure, you will achieve comparable early functional and oncological outcome between a very advanced multiport and a very first single port procedure. You have a slightly longer length of catheter OR time at the beginning, that this will go down rather quickly. You have a rapid learning curve. You know how to do a prostatectomy, or probably whatever other procedure you do as a urologist or as a gynecologist or general surgeon. So you do not need to start from zero again. You should expect more lymphoceles at the beginning when you do lymph node dissection and a lower lymph node yield. but you will have an extremely high acceptance on the ward and with the patients and with the anesthesiologist. And shortly speaking, you will be doing much better and much faster than in your very early multi-port days. With that slide, I would like to close and happy to take any questions. Thank you very much.
Thank you, Alex. My microphone is open, yes. Okay, thank you, Alex. It was a great talk.
Thank you.
Is there any questions from the audience to Dr. Alex? Yes. Yes, please.
Thank you. Great presentation.
Thank you.
Post-op complications,
Me
conversion rate, bleeding.
Yeah.
Mikrofonu uzatabilir miyiz?
So if we would convert intraop... Yeah.
Thank you.
So
Again, you mentioned in your presentations you had a bleeding in
Yes.
4 cases,
Yeah.
and you convert.
Yeah.
You convert to multi-port procedure or open procedure. As you know, the young generation, they don't know how to do open surgery whatsoever. Is that right?
correct. So
Thank you.
Fortunately, I belong to the old generation, as you can see. So fortunately, we had, during the procedure, no situation where we had to convert. And those patients who were bleeding the day after. And, but in both ways, we would go straight into an open revision. For the simple reason that we have the incision already made, and it's, as you see, we as dinosaurs in the field of robotics, of prostate surgery, to put it like that, we know how to do an open prostatectomy, and we have done it for decades. So for us, the burden is not as bad, and the incision is right there, so that's what you would do. It is correct that, of course, the generation that will follow us and proper sitting on our shoulders and being significantly taller than we are, they might have a scenario where they say, we have not done this before, we actually haven't seen it before. Almost a philosophical question. The response to that would be, but probably they don't see it so often anymore. Maybe they don't need it. We all know places where residents say, and we have residents who come from, or fellows who come, and they say, I am coming from hospital X or X. Do you know that I have never even seen an open prostatectomy because it hasn't been done here for decades? I don't know. That's what it is. But this is also one of the reasons why we are still quite happy to be able to fix a problem when we need to do it. But it's hard to answer. Short story, we would convert intraoperatively to an open procedure because the space is there. It's the space that we know from the open procedures. It's extraperitoneal. It's just the incision of the cut. And if it would happen afterwards, we would do it in the same way.
Any other questions? Yes, Abe.
Thank you for really good, excellent presentation. I want to ask you, we know from literature, Martini Klinik is famous in neurosafe.
Yes.
And do you use neurosafe in single port surgery?
Yes.
And if you do, how do you do? It can be maybe easy, for example, because we use access port. And can you explain how do you do in neurosafe?
Yeah.
And you do routinely or some certain patients?
So just a short explanation. What we do during what neurosafe means is basically a technology where we take out the prostate during the operation to have it examined to see if the cancer is cutting or touching the surgical margins, because you do not see it obviously during the surgery. And what we are doing is exactly as you say. You have the access kit. Once the prostate is separated, we just open the kit, take the prostate out, do the frozen section analysis, send it away, and then we just go ahead. It is in no way different from a multi-port where you just open the Alexis kit, take it out, and do the cut. So that is exactly the same, and we wouldn't want to do a single port if we couldn't do a frozen section on it.
Alex, when you get the positive results from the pathology at the during the operation, do you remove all the neurovascular bundle or just some part of them?
That depends on the size of the surgical margin positivity. If you have a surgical margin positive that goes beyond millimeters to centimeters, so a big positive surgical margin, you would take out the entire bundle. If it's a small one, you take out part of it.
Yeah.
But again, this is completely independent of single port or multi-port procedures.
Okay. Any other question from the audience? If not, we should proceed.
Thank you very much.
Okay. Okay, guys, all of you welcome.
Excuse me, one question.
Sorry. Yeah,
okay.
please.
Is it possible during the procedure to move the patient in a single port? There is any difference? I mean, if you need more Trendelenburg or some different situation in the left side, right side, flank?
The question is to yours.
Yes, sorry.
Absolutely no problem, because you have the access kit.
Yeah.
A flexible thing, right? So if during the procedure you have the idea, can I go into more Trendelenburg, you just push the remote button on for the table and bring in more Trendelenburg. Of course, you need to sort of pull back the instruments, but you do not even need to disconnect. So it's super easy.
Even in a left or right flank? This position?
As a prostate cancer surgeon, I have no idea what a right flank is, to be honest.
I mean,
no, but it's.
I mean, for some kidney
It
surgery,
is.
I mean, in the device, not especially for the prostatic.
It is. I have actually heard from people who know how to do it that if you do, say, a ureteronephrectomy, for example, that you actually move the boom of the single port according to your surgical field. So they go from all the way the kidney and turning all the way down. And if you need to reposition or elevate a little bit for better exposure of the region, that's what you can do during the procedure.
One more about the intravesical surgery. You don't mention anything. If you use the intravesical, there is some specific difference. Intravesical.
I didn't get that question. Sorry.
Okay, when you put the single port, you said that you can use it in intravesical surgery as well. Transvesical, okay.
So we have not done a transvesical radical prostatectomy yet. This is going to happen. Our plan is to have all of us as a surgeons have an established single port extra approach, and for early next year we will start with the transvesical and explore the possibilities of a transvesical radical prostatectomy. Professor Binbay has done, and so I'll ping pong that question to him, sort of.
Yes, I will share a video on that.
Okay, thank you very much. Thank you.
Okay. Microphone.
Yeah.
When you were answering my colleague about the bleeding,
yeah,
and that with the single port you already have the
incision.
the incision. Yeah. So, but if you have a multi ports, then you have to do another incision, right?
Correct.
Okay. So if you go for the single port, you make extension of the incision, or you just go with the same incision?
Usually, I mean, as the single port incision on a prostate that is about 50 grams is that big. So if you have a significant bleeding, you will not be able to visualize it open, so you extend that cut. If by default you had a somewhat larger incision, it may be that you get away with it, but that is really a situation-to-situation decision. By and large, though, when you want to have a good exposure of your surgical field in a situation that can be critical, which is bleeding, then you want to say, let's better have a more wide incision for the vision, because you want to find that bleeding fast, of course. So in that case, make the incision slightly larger, probably than you would think, just for the safety and rapid exposure of your source of bleeding.
Yeah.
But it will be the same incision. And in a multiport, you're right, we distribute the cuts somewhere here, and if you need to go back, it's the cut underneath the umbilicus, like in a classic open radical prostatectomy approach. So a big scar on top.
But this, let us take us to the, if you do a single port incision,
yeah,
and then definitely you do it because minimally invasive and all this stuff. But if you go with a little larger incision and you do the same for open prostatectomy, what is the difference in this situation?
Well, that is a very fair argument, and some of the, I would say, more skeptical patients say, doctors say, this looks like we have done 20 years ago, just a little bit smaller. And to a certain degree, they are right, because it's the same area that we are working in, and the incision is just a little bit smaller. And we need to ask ourselves, of course, what do we make out of it? And still today, given the overwhelming evidence and success of the robotic approach, it will be hard to argue that it is just an improved robotic open prostatectomy like we have done in 20 years ago. You stay extraperitoneal, right? That's what we have done earlier. But overall, you have the advantages of much less of a blood loss, and usually a better sphincter preparation, and usually we know that from the robotic experience, a better preservation of neurovascular bundles and potency. So it's true, if you look from the outside, it's only a smaller cut. But if you look at what it translates into long-term continence and potency, there we do see the superiority of the robotic approach combined with the extraperitoneal approach. And it's also true, there are some some surgeons who know how to do a multi-port extraperitoneal approach, because the extraperitoneal approach is there. It's the laparoscopic approach that I've never learned laparoscopy, but lots of people have done it. And some people actually know how to do a multi-port extraperitoneal approach, but it's certainly significantly more difficult because you need to create that space as well, which is more complicated than in a single port. And you have so much less space, so that clashing between the multi-port arms is more frequently. So that's one of the things to consider.
But you as an expert surgeon in open prostatectomy and then laparoscopic and then robotic, do you recommend that people move directly from the open to robotic, or they have to go through the laparoscopic era?
Well, I never done laparoscopy. I switched from open to robot. But again, it is what you are. And if you are in a certain situation, if you are an open surgeon, there is absolutely no need to say I need to go through laparoscopy and through the very difficult learning of laparoscopy just to be a robotic surgeon. You go from open right to the robotic. If you are a laparoscopic surgeon, actually, I trained a lot of laparoscopic surgeons as well, and they have certain advantages. First of all, because they, of course, know what it is like to look at a camera, and they know how to place a trocar and things like that, like the basic skills. But on the other hand, they have certain laparoscopic movements that are so difficult to wipe out almost, as you say, because they are not used to the wrist function. And so you need to really reprogram their muscle memory before they grasp the full potential of a wristed instrument. But anyway, if you are a laparoscopic surgeon, then you switch to the robot. If you're an open one, you switch, but you do not need to have that sequential evolution. It's absolutely not necessary.
Yes. Thank you very much.
Okay, no problem. We run out of time for the reason I am starting. Okay. First of all, before starting my talk, I would like to thank my CEO, my directors, the memorial staff, everyone for giving us this opportunity to meet with you here at this excellent meeting. Today's talk is Pioneering Single-Port Robotic Surgery in Turkey, Memorial Şişli Experience and Urological Applications. Before starting, briefly, I would like to introduce myself. I am Murat Binbay. During my urological practice for 25 years, in the initial 10 years, I was interested in the urinary stone disease, but nearly the last 15 to 16 years, I am deeply interested in uro-oncology and minimal invasive surgeries of the uro-oncology. A path that naturally led us to current pioneering work with the single-port robotic system. As we look at this timeline, we are not just looking at the history of a machine, we are looking at the evolution of our surgical craft. My personal journey crossed with the robotic system at 2009, and up to now, during the 16 years, I have performed nearly 1,500 robotic surgery cases with Da Vinci multi-port system. Okay, what was the problem with the multi-port Da Vinci system? I am a fan of multi-port Da Vinci system, but we had some problems. First of all, as a urologist, we are working on retroperitoneal targets. So kidney is a retroperitoneal organ, prostate is a retroperitoneal organ, but because of we need a large distance to conduct the multi-port system, we usually work through a transperitoneally. For that reason, sometimes we see transient subileus of the patients, more pain, prolonged hospital stay, and sometimes we have challenges placing the trocar in the hostile abdomens. And the second problem, in my opinion, is with the positioning, because for the multi-port systems, we take the patients in 30-degree Trendelenburg position for most of the prostate cancer cases, and lumbotomy positions for the kidney surgeries. And when the operation time prolongs, these patients have some muscle pains, and if there is some hernias, spinal hernias, these patients suffer from some kind of different pains after the multi-port surgeries. The Da Vinci SP system is not a new system. The FDA approved it for urological procedures in 2018. So we have nearly 8 years data for SP, and it is a confident surgery for urological operations. What is our goal with the SP? Without losing any oncological results, without losing any functional outcome, we are trying to give a patient less surgical trauma, less pain, and faster recovery, and SP is used for that kind of aims. You see, instead of a 4-hole, we open a nearly 3 centimeter single hole in the system, and one thick trocar is placed to the abdomen, and all the instruments are articulated inside the body. Alex told you more about that. For that reason, for our time limitation, I am passing it. You know, the key advantages: minimal trauma, faster recovery, and cosmetic purposes. But seeing is believing, you know. I will show you a case just 18 hours after the surgery. This is a young lady, 41 years old. 4 months ago, she underwent a gynecological surgery, open gynecological surgery. For that reason, she can compare both operations. Can you open turn on the voice?
Dün ameliyat ettiğimiz hastamızın yattığı kata geldik. Şimdi içeri giriyoruz.
This is just 18 hours after a partial nephrectomy.
This is very important for us. Why? Because you are one of the initial cases of the single port robotic surgery in Turkey. For that reason, everyone is curious about how a patient
Normally,
feels
after
the surgery.
multi-port partial nephrectomy is usually when I see the patient at the post-operative day 1, usually the patient suffer from serious gas problems, a distended abdomen, but you see, this is just 18 hours, post-operative 18 hours. All the aim to use a single port is to catch this patient's smile.
Now,
This is the incision.
we don't
Yes.
give you a serious painkillers. Can you believe it?
Okay. Of course, all the things has every new device has advantages, but also limitations. What are the limitations of the single port surgery? There's a steep learning curve, really, and it requires 10 to 25 centimeters of internal working room. It is less flexible in very small bodies. It's an expensive technology. I should mention about it. Sometimes there are anatomical challenges for big prostates, for the patients with morbid obesity. These cases may be more challenging for the surgeons. Can we buy just a single port instead of a multi-port system? No. You can turn off the voice, okay. This is the first day when our single port system was set up in our operating room, and multi-port system welcomed it with a rose in the first day. But I should say that a hospital cannot rely exclusively on a single port system. Since different surgical indications and anatomical challenges require distinct approaches, it is essential for a multi-port and single-port robotic platforms to coexist within the same institution. Okay, let's talk about our story. This is the first time I sat on a single-port system during the World Endourology meeting in Korea, and I was excited with the system. You see here, and when I come back from the Korea, I knocked our CEO's door and talk about buying a single port system. They refused me 3 times because the system was not cost effective according to their opinion, but because of they are a young generation, they are following the technology and open-minded, so they decided to buy the robotic system. The decision was given immediately in December 2025 because our goal was to be the first hospital doing the robotic single port surgery in Turkey. For that reason, when I took the news that we are going to buy the single port robotic system, we started to our single port training program. First of all, we talked with Dr. Alex Haese and we fly to Martini Klinik. I should say that it's a very well-dedicated, excellent clinic. Alex did 2 single port radical prostatectomies, and one of them was a very tough case. And at 1:30, the surgery, both surgeries was completed from skin to skin. Then, 1 day later, we stayed there 1 day, and at the evening we turned back to the Istanbul. But just 12 hours later, we fly to Atlanta with my colleagues, Dr. Yılmaz Salman. This is the photo from Atlanta, United States, and we completed the certification of the single port robotic surgery. We trained on the pigs. Then we were talking with Alex that we were planning to do my first operation in 10th of January, and Alex would join us for the first operation. But at that time, there was a problem with the customs, and I heard that the robotic surgery system was not going to be set up till 15th of January, and we canceled the Alex program. But when I was staying at the hospital at the 9th of January, I heard that the system is going to set up just in 1 hour. I was patient. I have scheduled patient for the radical prostatectomy, so we decided to do the first surgery in January 10. This is the success photo after the first surgery, but the problem was just, this is an immediate scheduled program. Just one day, a couple of hours before the surgery, I look at the volume of the prostate. It was a huge prostate. Then I remembered our conversation with Alex. Alex advised me to start with the 60 gram of prostate. Then, by experience, you can go to the 80 gram, then 100 gram. And I asked Alex that, Alex, you are a very experienced surgeon. What is the biggest prostate of your experience? He said me that I did 140 gram. And I was shocked at the moment, but God helped us for that reason. First, of course, at that time, I would like to thank Alex for his great host and showed us all the tricks of the single port robotic surgery. And Alex visited our clinic 1 week later. I was doing the 4th case. Alex, you remember it? You have been with us at the 4th case and sent me a very gentle message. Thank you again for your kind message, a motivated message from my mentor. Thank you very much. Okay, up to now, during the last 4 months, as a urology team, we did 30 cases, and 27 of them was done by me and my team. When we look at the breakdown of the procedures, most of the cases are, as expected, radical prostatectomy. but we did partial nephrectomy, transvesical prostatectomy, and bladder neck reconstruction. And during these 27 cases, there was no drain replacement because in the beginning I was asking Alex, can we put a sidecar? He says, no, no need, no need. He forced me not to put a sidecar or any additional trocar. For that reason, up to now, there was no drain replacement, there was no blood transfusion, there was no ICU unit admissions, no additional instrument addition, and no surgical conversion. In which surgeries we use the single port SP robotic surgery in urology? Of course, robotic radical prostatectomy comes the first. For partial nephrectomies, I think this is the second beneficial part. Nephroureterectomies for local upper urinary tract systems, in my opinion. And the fourth one is the BPH. If a patient has a prostate more than 200 grams, without minimizing the urethral stricture race and the incontinence race, I think single port BPH surgery should be the one of the option. Okay, Alex told many things about the radical prostatectomy, but this is the evolutionary path of radical prostatectomy. Nearly 60 years ago, the modern radical prostatectomy was discovered, and then attempts to minimize the trauma in 1992, laparoscopic radical prostatectomy was described. But the laparoscopic instruments had no articulation. For that reason, in the beginning of 2000s, robotic surgery released in the market. But we learned much about the anatomical details, and with the anatomical refinements, in 2010, ratio-sparing radical prostatectomy was described, and now with the ratio-sparing radical prostatectomy, the patients control their urinary continence more earlier, and with the SP gives us port consolidation and new approaches for us. This one of them is the transvesical route. Transvesical route, I describe transvesical route as extraperitoneal ratio-sparing surgery. For that reason, giving the advantages of the extraperitoneal route and having the ratio-sparing abilities, I think it will be very special technique. In the transvesical technique, you avoid the peritoneal cavity, you have the faster bowel recovery, preservation of the rescue space is important. These are the main things, but you should select the patients less than 80 grams of prostate. There should be no bladder cancer. There should be no need for the lymph node dissection. And if you are going to preserve the bladder neck, this technique is not appropriate for you. Your question, one of our friends was asking about the transvesical radical prostatectomy. I tried in one case, there was a hostile abdomen, aortofemoral bypass. In that case, the prostate was around 50 grams. For that reason, I decided to do the transvesical prostatectomy. I can say that the most difficult part is the anastomosis for that system. You see here. But the benefit of this technique is this technique makes the radical prostatectomy as a same-day surgery. In the morning, in United States, you do the surgery in the morning and send the patient home at the evening. Of course, for our country, the patient doesn't want to go at the same day, but next day you can send them if there is no complication. You see here, if you select the optimal patient for this technique, you see an amazing view from here. And with this technique, this technique was described by Cleveland Clinic, Dr. Kauk. And with this technique, they remove the urethral catheters just 4 days after the surgery. But this SP system is very useful for the transvesical operations. One question for me in my mind, transvesical approach is better than transperitoneal approach. But what about the extraperitoneal approach? When we compare it with the extraperitoneal approach, early continence rate is higher in the transvesical group. For that reason, it's a good option. What about the transvesical prostatectomy? This is a good access for the benign prostate hyperplasia, but you, as a urologist, you should ask me. There is a laser enucleation, and this is minimally invasive, less invasive than the single port surgery. I can say that with the SP robotic adenomectomy, you can have information about the exact pathology. You have anatomical precision. You have lower urethral stricture rates. I think it is very important, and lower incontinence rates. You can manage complex cases in just one stage, and it is a shorter learning curve for the robotic surgeons. For that reason, if a patient has more than 150 grams of prostate, SP robotic adenomectomy should be considered. Partial nephrectomy. This is the one of my favorite and one of my expertise, because I have nearly 400 partial nephrectomy, robotic partial nephrectomy experience, and I did many challenging cases, and I am very comfortable with the partial nephrectomy. And the study says that SP partial nephrectomy has a longer warm ischemia time. But for, of course, there is a spatial technique, and we can do with the single port robotic surgery, we can do the partial nephrectomies in supine position. I think this is a very serious improvement. And in SP, there is a very important technical advancement. You see this is the lower pole kidney tumor. The tumor is down, and I am working on the console like that, with my right hand, but to the reverse angle. But there is a button. This is a mirror effect. Then when I press it on the right hand, I use my left. But I feel that I am using my right hand at the moment. For that reason, my manipulations get easier when I press this button in the proper situations. This is a serious technical advancement. Which kidney tumors are difficult to perform with the SP? Upper pole tumors, but we also experienced an upper pole tumor. This was an endophytic case around 4 centimeters located in the upper pole of the right kidney, and with a warm ischemia time less than 20 minutes, we did it. The problem is with the clips, the assistant should put the hemolog clips through this spacious Alexis trocar. Sometimes it is difficult to place these hemolog clips. And this is the incision. This is the low anterior access. This is important position for SP, robotic SP, because through this incision we do the partial nephrectomies, we do the nephroureterectomies, pyeloplasties. For that reason, this is useful technique. I have not used this technique yet, but probably in the near future we are going to try this technique as well. So if we do the partial nephrectomies or the other operations in this position, the hospital stays decreased to 10 hours after the operation. For partial nephrectomies, we should select the cases, especially for renal score less than 7, tumor size less than 4 centimeters, not an seriously obese patient. If you can do the surgery with standard renal and reconstruction, you can prefer SP system, but the most important thing, before doing a partial nephrectomy with SP system, you should have an experience of at least 50 partial nephrectomy with multi-port robotic system. Okay, after that time, I will talk about the reconstructive surgeries of the SP. For that reason, I would like to invite my colleagues to the stage, Dr. Abdülmuttalip and Dr. Eyüp Veli Küçük, and Yılmaz and Serdar. Okay. Dr. Abdülmuttalip Şimşek is a very well-known reconstructive surgeon in our country. For this reason, the first question should go to him. What do you think about the bladder neck reconstruction and the posterior urethral strictures? Can you say that this SP system is beneficial for the bladder neck reconstruction and the urethral strictures?
Thank you very much. It's a good question. The first, thanks all to come to here, then the Memorial Hospital to share us in this beautiful meeting. The recons, I think, in the near the future will give a huge opportunity for the single port, because the bladder neck structure or bladder neck stricture, it is really difficult to doing the operation. The first, we are doing the perineal approach for that cases, but all the cases say to me, doctor, yeah, after the bladder neck reconstruction, we have incontinence. Maybe 100% patient have incontinence after perineal approach. For the robotic surgery and the SP, we just going inside of the structure area and the removal or the fibrotic tissue, and then doing the re-anastomosis. So it will be easily for us doing the SP. And normally I do multi-port with this approach, but yeah, SP is with good for us.
For bladder neck reconstruction, do you think that transvesical approach is a better way, or extra extravesical? Because, you know, you can
understood.
take a bladder flap.
If the patient have a radical prostatectomy, extravesical approach, you need to do that one because you need to remove whole of the fibrotic tissue. But if the benign, after the benign problem to coming that, you need to go to intravesical approach and remove the fibrotic tissue, then put some of the grafting. I use the oral mucosa all time.
Okay, okay, thank you, Abdülhamid.
You're welcome.
Okay, Oktay, my question is to you. You have also long-term experience in the Netherlands. Yes, this is different, but you have robotic experience. What do you think about using a single pore surgery for a pyeloplasty?
For a pyeloplasty, this will be really very first opinion of me on the single port robotic surgery. As you mentioned, I have had a scheduled program, a training program in the Netherlands for the robotic surgery. Of course, it was on the multi-port system, but I have some experiences with dry lab, wet lab in a single port. I've seen it. I don't have any single port real case experience in the OR, but I can say that with my experience in the multi-port on pyeloplasty, pyeloplasty was one of my first cases in multi-port system. Probably it will give us more precise surgical field for pyeloplasty because during pyeloplasty we don't need that big spaces compared to partial nephrectomy, compared to maybe prostatectomy. So maybe the pyeloplasty will be the one of the best options for single port prostatectomy, single port system.
Okay. Okay, thank you. This is the urethral implantation. We can do the urethral implantation. Would you like to say anything about the urethral implantation, Abdülhamid?
I think for the single port or the multi-port, the reconstruction is important for us. I know the maybe 30% of here general surgery and gynecologic surgery is a true and pediatric surgery. So with fistula repair for urethral reimplantation with the buccal mucosa or with ileal reanastomosis, we can do easily. But in the gynecologic problem, I will say the reconstruct all, is it true? All the fistula or urethral reimplantation. For the pediatric cases, for example, we do urethral reimplantation with the body flap with the robotic. But in the pediatric, we use forearm. It is really be like an open surgery. You open the all area, but for the single port, just 3 centimeters in the midline, and you do all the things that one. For fistula repair, I know that in African people, there are a lot of the vesicovaginal fistula is a problem. The Gökhan is here, so the Taha is here as well. So with the single port repair, it will be easily for us because doing the transperitoneal approach and sometimes with the peritoneal flap is coming there or its omentum is coming there and the patient discharged too easily, maybe 1 or 2 days later with the 100% of the success rate. That's why.
What do you think about the vascularization? Because with the multi-port system, the closing force of the instruments are higher than the single port system. For that reason, maybe SP is more beneficial, maybe better results with the comparing to the multi-port system because you know the vascularization of the healthy tissue is important, and when you hold it with the instrument, sometimes we know from the cystectomy series, for that reason, the urethral stricture rates are higher with the robotic multi-port system. What do you think about it? Do you think that SP with having a less closing forces of the instruments, you can have the better results with SP?
I think it depends. If you stay to hit too hard, and we use ICG all time, how is the vascularization is the good or not for Firefly technology?
Yeah.
For recons, yeah, you are true. Forearm is difficult to doing the anastomosis. To me, no. The multi-port is easily for the recons, I think. But it's the beginning for me. Maybe it's more difficult for us.
Yeah. Okay. Thank you. And about robotic adrenalectomy, Dr. Eyüp Veli Küçük is my friend from the medical faculty. We studied 6 years together. And Eyüp, you have many experience with the multi-port robotic system. Can you add some comments on the adrenalectomy and the retroperitoneal lymph node dissection? Do you think that we can achieve better results with the multi-port system, or single port can find a place for this kind of operations?
Yes, actually, you said thank you. I had a good experience for multi-port, and of course we are the new in single port, and maybe little case, but we learned something from the single port. For example, about adrenalectomy, can I say we use multi-port. Sometimes we do space for our surgery. Sometimes we need to space for our instruments. When we use multi-port, we have to calculate our instrument space every time. And for example, in adrenalectomy, if we do SP single port, we can concentrate our region. And sometimes we use deeply incision, and when you go to the deeply, you have to calculate all your instruments. And maybe it's advantage for single port. When you go to the adrenal area, only you can use the small space. Sometimes we complain about the single port. It's a really restricted surgery area. But it can be an advantage for this position. And the other things, the retroperitoneal lymph node dissection is a really hard surgery. Of course, we use in multi-port in really good experience with it. Sometimes if a little or only one oligometastatic situation in retroperitoneal, we can easily focus them, and we can reach them easily.
From my view, for retroperitoneal lymph node dissection, I may prefer the multi-port system because I am working on very important vessels, and if I don't have a suction during the surgery, if it bleeds, I may have a serious
I said
trouble.
only one lymph node, maybe you can focus them. But if you do template dissection, of course you need more instruments.
Yeah. Okay, last question to my teammates, Dr. Yilmaz Salman. We are working more than 1 year together, and we started our single-port robotic surgery program together. Maybe, Yilmaz, you can add something about what's the difference for the multi-port assistance to single-port assistance.
Thank you for your great presentations and for your kind words. I am very glad to be part of the first team to perform the single port operations. At the beginning, we visited Dr. Alex for observation. I would like to thank him again, for his great support. About the question, Yes, there are technical differences. Like Dr. Ali said in this presentation, first of all, in single port, there is no separate assistant port. There are two ports on the access port kit, but its workspace is very limited. Because of this, the console surgeon has to perform two most tasks, such as aspiration, retraction, and clipping. In multiport, we use an extra assistant port. This makes assisting the console surgeon much easier. However, in single port, preparation stage is very important. In this stage, we must check the distance between incision, the surgical field, and surgical field. The distance should be between 10 to 25 centimeter. Sorry. Additionally, we must check set CRC, a custom limit center, and pitch limit set. This custom limit center is the pivot point of the robot. If it is too deep, the access port rings presses the abdominal wall and narrows the surgical field.
So preparation, the setup is important, but from our talk with Dr. Alex, I understand that the assistant should be more dedicated to the surgery because of the smoke. What do you think, Alex? The assistant should suck immediately when you cut. For that reason, the assistant should be more involved in the operation.
Well, if you compare a 3-person approach to a 2-person approach on multi and single port, then it is true that some tasks that the bedside surgeon would do are controlled by you as a console surgeon. And therefore, to a certain extent, you have more workload. That overall reduces the entire workload that needs to be done on the patient. But what is left as a workload is getting more important. And that is the, for example, help with the suction, proper aspiration, suction when you need it, not too much, not too little. It's good when you have a surgeon, a nurse who sees when to give a small suction and when to stop. And of course also things like bringing in needles, cutting something, all these things together are not so many anymore, but these need to be done in precision and in harmony with the surgeon. So the answer is yes, you rely on a very good bedside surgeon to make what is left more streamlined so that the two of you work more smoothly together. But again, because you're only two, you have to interact with only one person. So it's not that you have to speak to the bedside nurse and the bedside surgeons and they talk to each other who's taking what task. It's a more direct communication between the two involved. And that makes it easier, but requires more responsibility on the small tasks, but important tasks that are left to the, in this case, nurse.
Okay. We are run out of time. For this reason, I should close the session. If you have questions, you can ask the questions on the... Okay, okay, last question. Yeah, yeah, yeah.
So just in percent, what is the difference between the multi and the single port expenses? Just percent.
Two times. 2 times for instruments. Of course, this is for our country, but in each country has their own cost. I don't know about it. Oh, okay. Okay, last question.
Dr. Dentsu from Gabon. I would like to begin by thanking the entire organization that made it possible for us to be there today to participate in this scientific meeting. And I want to express my sincere gratitude to all the speakers. So I have a question. My question is, I would like to know how long does it take to train an experienced surgeon in this technique in order to use its proficiency? And is it the same time for multi-port and for the single port? And also for the new generation, do you think it's the same time for the old surgeons if they have to learn this technique, or for the new generation?
Okay,
Thank you.
we should ask this question to the most experienced person on the stage with SP and multiport for that reason. What do you think about how we should train on the SP? Start with the multiport.
Naturally, what in today's situation, you will rarely find, or probably not at all find, a single port as the first robotic platform in any institution. So it is quite normal, I would say, that anybody who switches to a single port has some multi-port experience. That is the current landscape. There is absolutely no doubt, though, that there will be one day that one surgeon who will start on the single port. Because for whatever reason, maybe he says, I will avoid the multi-port, I just don't want to do it, or for the maybe remote scenario that a single port is installed in a place as the first robotic system. And then we will see. But technically speaking, I would not see any worries about it, because it is, you teach somebody on a technology, and if you teach somebody on a single port system who starts from zero, or on a multi-port he starts from zero, he will need to learn the procedure, that's one thing, and he will need to learn how to operate the device to do the procedure on the other end. And whether or not it is easier for a novice surgeon to start from zero and do a good, for example, prostatectomy on a single port when he hadn't done any multi-port, or if he starts on a multi-port, which we all have done, nobody knows the answer. I personally would not see a difference, because it is just a technology that achieves an operational output. And there is no reason that one or the other should be easier in terms of the skill that you need to do the operation.
Okay, thank you guys. I'm closing the session.